Morning. Welcome to the next edition of Science Now. This is our venue for showcasing exciting research that's going on right here now in our department. So today we're going to feature two of our exceptional physician scientists who are also great models for our trainees. And you'll see that their research programs are very much framed by questions that they see every day in their clinical practice. So our first speaker will be Dawn Davis from the Endocrine Division. She's going to talk about a new discovery of hers for an unexpected role for gut hormone in beta cells and the therapeutic implications of that. And then we'll kind of shift gears, and Loren Denlinger, fresh from his stint as TLC attending, will talk about some interesting findings about a subset of patients with severe asthma who are exacerbation prone, and how we might need different therapeutic approaches to these patients. So there'll be a few minutes for questions after each presenter, and let's get started.
Okay, let's see. Okay, good morning, everyone. Thank you all for coming in this morning. So it's my pleasure to talk to you guys today about some of the work that's been going on in my laboratory over the last few years. I'm going to talk to you about some new hormones that we have discovered are produced within the pancreatic islet. So it's not all just insulin and glucagon. So to remind everyone in the audience, the pancreatic islet is a small mini organ, basically a mini endocrine organ within the pancreas. And within the pancreatic islet are a number of endocrine cells that produce different hormones. This is a mouse islet here with insulin stained in red, glucagon stained in green, and somatostatin stained in blue. And this is a human islet with the same staining colors. And what you can see right away, I think, is that mouse islets have a lot more beta cells than human islets, but both islets are predominantly made up of these three cell types. So we actually know that reduced beta cell mass is a key feature in the pathogenesis of type 2 diabetes. So we all know that type 1 diabetes is caused by a reduction in beta cell mass. But what we see is that also if we compare lean or obese individuals without diabetes with lean and obese individuals with type 2, we see this dramatic reduction in beta cell mass. This is autopsy data, so we only really are looking at the end of life here. But we think that one of the reasons that we end up with this reduced beta cell mass is because individuals with type 2 diabetes are known to have increased beta cell death. Beta cell apoptosis occurs at higher rates in both obese and lean individuals with diabetes compared to non-diabetic weight match controls. So unfortunately, this loss of beta cell mass is part of what leads to type 2 diabetes as well as type 1. And so really one of our goals of diabetes prevention is to try to preserve this functional beta cell mass, and our main goal of diabetes therapy is to try to restore functional beta cell mass in people who have already lost a substantial amount. Unfortunately, none of our current therapies actually directly target beta cell mass and allow us to restore or prevent progression to diabetes. The one therapy class that comes closest to this is drugs based off of the hormone glucagon-like peptide 1, or GLP-1. So a relatively new class of diabetes medications are GLP-1 analogs. So GLP-1 is a small peptide hormone that is produced predominantly in the neuroendocrine cells of the gut in response to a meal. And it is known to stimulate pancreatic islet insulin secretion, as well as many other effects throughout the body that lead to beneficial impact in diabetes, including satiety, delayed gastric emptying, and some improvement in insulin sensitivity. So there have been a few studies, predominantly in rodent models, showing that that GLP-1 or its analogs can promote functional beta cell mass and potentially prevent apoptosis. And the pathway through which that occurs is that GLP-1 binds to a G protein coupled receptor and activates the G alpha subunit, which then activates adenylate cyclase to generate cyclic AMP. And through downstream signaling from cyclic AMP, we get promotion of a lot of these pro-survival pathways that allow beta cell survival, including reduction of endoplasmic reticulum stress and protection from cytokine-mediated inflammation and apoptosis. Ultimately, a lot of this works through a downstream transcription factor known as CREB, or cyclic AMP response element binding protein. So the other hormone I'm going to be talking with you about today is the hormone cholecystokinin, or CCK. So many of you, I'm sure, remember learning a little bit about CCK back in medical school, but in clinical practice, we really don't think about CCK very much. CCK is a hormone that, again, is also produced in the neuroendocrine cells in the gut in response to a meal. And it's best known really for its role in digestion, where it stimulates exocrine pancreas secretion, as well as contraction of the gallbladder. It also decreases gastric motility. But a couple of other important things is it works a lot in the brain. There's actually a lot of CCK produced in the brain, and it can stimulate satiety. And it also can stimulate insulin secretion, however, not quite as strongly as GLP-1. So given this, CCK has been studied as a potential therapeutic, not just for diabetes, but also for obesity, given its roles in satiety. However, it's never really made much progress in pharmaceutical development for a few reasons, partly due to side effects from the other GI effects it can have. But some of the promising data that is out there is shown here. So one of the defects in type 2 diabetes is a reduction in secretion of both of these hormones, actually GLP-1 and CCK, from the gut. And what we show here is that in normal individuals, there's an increase in CCK in response to food intake, and that response is blunted in individuals with type 2 diabetes. So these individuals don't make as much CCK. However, if we take an individual with type 2 diabetes and we infuse CCK, what we see here is that, again, the control type 2 diabetic patient has a dramatic rise in glucose after the meal, whereas the patient treated with CCK is basically protected from that and has normal glycemia after the meal. Similarly, there's a slight increase in early insulin secretion in response to CCK infusion in type 2 diabetes. There's also a relatively large literature from the past couple years from a group out of the UK where they have used a CCK analog, which is a longer-acting analog of CCK. These are all rodent studies. So in these rodent models, they've shown that CCK can protect from obesity. So these are high-fat diet-fed animals. And again, the normal controls here gain weight on a high-fat diet, but the animals treated with CCK basically maintain a weight similar to the lean control group. So CCK infusions are able to protect from obesity in mouse models, and also to normalize glucose tolerance in this same model. So here again, the control mice on high-fat diet have impaired glucose tolerance. Their glucose goes up too high after a glucose challenge. But the animals treated with CCK are protected and therefore have glucose tolerance similar to the lean controls. So putting this all together, we already see that CCK has several potential positive roles in the treatment of obesity and diabetes. It can reduce weight in obesity or prevent weight gain. It can improve glucose tolerance, and it can improve insulin secretion. So it seems that CCK has significant potential as a therapeutic agent for both diabetes or obesity. So now we're going to get into what we've been working on. So interestingly, several years ago, we identified CCK, the gene, the transcript of CCK, as the most upregulated gene in mouse islets under the condition of obesity. So what we're looking at here is a micrograph, and you can see that these lean mouse islets with insulin stained in red have very little production of CCK, which here is indicated in green. However, if we look at an obese mouse islet, you can see green all over the place. So there's a dramatic upregulation of CCK in response to obesity in the mouse islet, and this is predominantly within the beta cells of the islet. And this is just looking at the actual protein levels, so there's really no detectable CCK within the islet of a lean mouse, but obese mice have significant amounts of CCK production. So this was really surprising because, again, CCK is known to be produced within the neuroendocrine cells of the gut and in the brain, but there had been really no prior knowledge that CCK could be made within the pancreatic beta cell, particularly because that cell is very specialized for insulin production and shouldn't really be turning its efforts to making a new hormone. So we wanted to figure out what could be the purpose of this. Why would the beta cell suddenly shift to producing another hormone like CCK? So we took the same obese mice where we knew CCK was upregulated, and we looked at them under conditions of a CCK knockout. So if these mice cannot upregulate CCK, what occurs? And what happens is that they actually develop a mild form of diabetes, and we see that their beta cell area is dramatically reduced compared to the control mice that don't have the CCK knockout. And when we looked at all the different things that can impact beta cell mass, what we found ultimately was that these knockout mice had an increase in beta cell death as measured by tunnel staining here. So when you lose this ability to upregulate CCK in the setting of obesity, it results in increased beta cell death and therefore reduced beta cell mass and diabetes. So what this told us that CCK was necessary to help protect from beta cell death or apoptosis and prevent hyperglycemia. The next question we wanted to answer was, can we force overexpression of CCK within the islet and see if that will actually protect directly from beta cell death? So rather than it being necessary, is it actually sufficient? So we created a mouse model here where we have the mouse basically produce the cholecystokinin under control of the mouse insulin promoter. So it's going to express CCK within any insulin-producing cell, like the beta cell. And we show here that this leads to a dramatic increase in CCK production, both at the mRNA level in the islet, also a dramatic increase in CCK protein expression within the islet, and the CCK is fully processed and secreted. So these mice are making functional CCK from their beta cells. So then we wanted to directly test, is this functional CCK production able to protect from a model where we induce beta cell death? So the model that we used here is what we call low-dose streptozotocin. We treat with drug streptozotocin, which directly causes beta cell death in a specific manner. And you can see in black here, the wild-type animals treated with streptozotocin develop hyperglycemia within about a week or two after the treatment. And this hyperglycemia persists for about a month. However, our animals that overexpress CCK only within the beta cells, so we're not giving them more CCK globally, and in fact, when we measure in the serum, they don't have any increase in detectable CCK in the serum. Just producing CCK within the beta cells protects these mice from beta cell death, and therefore from hyperglycemia. And we directly measure beta cell death down here using, again, this tunnel assay where we're marking apoptotic cells in green. And when we quantify this, we again see this dramatic reduction in apoptosis in response to this toxin, suggesting again that CCK is able to directly protect from beta cell death. And importantly, it can do this by just acting locally within the paracrine environment of the islet. So the next question we set out to answer is, what is it that regulates this dramatic increase in CCK? So why would an obese mouse islet start making a bunch of CCK, and how is this process regulated? What signal is leading to this increase? So we went to the literature and to some of the databases to look at what may regulate CCK promoter activity or CCK transcription. And what we found was that the CCK promoter contains a cyclic AMP response element, or a CRE, and this is conserved in the rat, mouse, and human version of the promoter. And digging back through the literature, there were some older studies in neuroendocrine cells that suggested that this cyclic AMP response element was active and responsible for CCK transcription in other cell types. So we wanted to know, could CCK be regulated by cyclic AMP within the beta cell? And to remind you, so I told you earlier that GLP-1 is a hormone that we know works at the level of the beta cell to stimulate insulin secretion, and GLP-1 also can signal through cyclic AMP. So we wondered, could GLP-1 through cyclic AMP be regulating the production of CCK? And the reason we were also interested in GLP-1, not just because of its role as a pharmaceutical agent that we use in the treatment of type 2 diabetes, but also because in the last few years there's been some emerging evidence that GLP-1 may in fact be made directly within the islet as well. So a couple studies early on showed that GLP-1 was upregulated in response to pregnancy or other stressors within the alpha cell of the islet. And this actually kind of makes sense because what we know is that the alpha cells are predominantly set up to produce glucagon. And glucagon is formed initially as a propeptide. And this propeptide contains both glucagon, but also contains GLP-1. So they're actually made from the same gene and the same peptide. And then whether a cell ends up secreting glucagon or GLP-1 depends on whether it expresses these enzymes, prohormone convertases, that will then cleave this propeptide into either glucagon or GLP-1. So it kind of makes sense that an alpha cell that's making a ton of this pro-glucagon peptide could switch over to producing GLP-1 by simply turning on expression of this prohormone convertase 1. So we developed a hypothesis that perhaps GLP-1 could be produced locally within the alpha cell and then feedback and regulate neighboring beta cells to stimulate the production of CCK through cyclic AMP-dependent mechanisms. So the first question we needed to answer was, we knew that from the literature that there was some evidence GLP-1 may be upregulated in other stress conditions like pregnancy and cytokine-mediated stress, but we didn't know if it was truly upregulated in obesity. So we looked actually in both human and mouse islet, and so what we're looking at here is the amount of GLP-1 that's produced from the islet and secreted into the media. And we look at human islet donors, so these are from deceased organ donors, and based on the BMI of the donor, we see that there's an increase in GLP-1 production in response to the BMI of the donor. In other words, more obese individuals produce more GLP-1. However, all of these individuals, whether they were lean or obese, seem to be secreting a certain amount of GLP-1 into the media. So human islets are making GLP-1, and this seems to be increased in the setting of obesity. Similarly, our mouse model that we used to initially identify this upregulation of CCK also demonstrates a significant increase in GLP-1 production in the obese state, which correlates really nicely with what we see for CCK production. So there's a correlation, but obviously not yet a causation. So then we directly tested whether if we put GLP-1 on the islets, can we stimulate those islets to start making CCK? And in fact we can. So here we're looking at different increasing concentrations of GLP-1, and we see that we can stimulate the production of CCK messenger RNA, but also fully formed protein and secreted protein into the media. So treatment with GLP-1 on a mouse islet, this is on a beta cell in culture, leads to the production of CCK, So we wanted to kind of move down the pathway. So if GLP-1 can lead to CCK production, can cyclic AMP treatment lead to CCK production? And the answer is yes, it can. So if we treat, again, beta cells with CCK, or with cyclic AMP, we see an increase in CCK messenger RNA and in secreted CCK in the media. So cyclic AMP can directly exert this effect. And then we wanted to return to, again, the mechanism at the level of the promoter. So that cyclic AMP response element in the promoter binds to this transcription factor called CREB, or cyclic AMP response element binding protein. We see that when we treat an islet with cyclic AMP, we see an upregulation in CREB. So that is expected. We see that that transcription factor is produced in response to cyclic AMP. And then we show here in a chromatin immunoprecipitation assay that the CREB is directly recruited to this response element within the CCK promoter. So what we're doing here basically is we take the cells after treatment with cyclic AMP, and we cross-link any protein that might be bound to the DNA. We pull it all down, and then we look to see if that protein was bound to this specific region of the DNA. And what we found, again, is that that CREB was localized to this cyclic AMP response element. Both RNA polymerase and CREB, were localized there, but we didn't see any localization to a downstream cyclic AMP response element within the CCK gene itself. So this response was unique for the promoter region and told us that cyclic AMP has a direct effect there to activate CCK transcription. And that was treatment with cyclic AMP. We also showed the same effect if we treat directly with GLP-1. So GLP-1 can regulate CCK transcription through this transcription factor CREB. And that was, everything I just showed you was all kind of in vitro data from a cell line, and we wanted to go back to the mouse islet to see if this was a physiologically relevant pathway. And so we went back to those obese mouse islets, and what I'm showing you here is basically, again, that cyclic AMP response element within that obese mouse islet is recruiting this CREB protein, and therefore we see that this same pathway seems to be upregulated in obese mice. Therefore, this is at least part of the physiologic pathway that's leading to the CCK production in obesity. So interestingly, I told you that prohormone convertase enzyme that leads to the production of GLP-1 also contains a cyclic AMP response element in its promoter. And this is just preliminary data so far, but what we have seen is that these same obese mice also have an upregulation of CREB recruitment to this promoter, suggesting that cyclic AMP and CREB signaling are also regulating whether or not an alpha cell may turn on GLP-1 production. So the overall model that we have developed here is that we think that GLP-1, which we think is probably coming from local production from an alpha cell, is then signaling back on the beta cell through its receptor, leading to an increase in intracellular cyclic AMP, and ultimately leading to activation of CREB and recruitment to the CCK promoter. And then that CCK is transcribed, translated, and ultimately secreted, and then can feed back on its own receptor on the beta cell to prevent apoptosis, as we showed in our mouse model. And we also have in vitro data suggesting this pathway is active as well. So one of the questions we were kind of curious about is, because we know that GLP-1 can protect from apoptosis, is it possible that the way GLP-1 protects from apoptosis is through this pathway rather than a direct impact on apoptosis? So could it be dependent on its ability to upregulate CCK production? So we tested that by taking, again, beta cells in culture. And if we treat those beta cells with cytokines, we see an upregulation in cell death, as measured here by CHOP protein production or as measured by tunnel. And then if we treat the same cells with GLP-1, we see that that apoptotic rate is decreased, as was already known in the literature. But interestingly, if we now include a receptor inhibitor for CCK, so proglumide inhibits both CCK receptors, we can basically blunt the ability of GLP-1 to protect from cytokine-mediated apoptosis, suggesting that the ability for GLP-1 to prevent apoptosis may be partially direct, but also is somewhat dependent on this entire pathway. So this is kind of an entirely new mechanism where GLP-1 leads to this beta cell apoptosis prevention. And then the other part of this that I didn't really talk about yet, and we're still working on validating and working this out, is that perhaps that CCK could signal back to the alpha cell, because we know cyclic AMP is upregulated by CCK signaling to activate CREB and then lead to GLP-1 production from the alpha cell, creating a positive feedback loop that ultimately allows that obese islet to upregulate all of these pro-survival pathways and survive under the relatively toxic conditions of obesity. Interestingly, we wanted to look a little bit at type 1 diabetes models. So everything I showed you was obesity as a model of type 2 diabetes, but type 1 diabetes is also, in the early phases in particular, beta cells are still around, but they're under a lot of stress from cytokines and other inflammatory processes going on in the autoimmune state. So we looked at the NOD mouse, which is a model for type 1 diabetes, and if we look at these animals in the pre-diabetic state, we see that CCK is also dramatically upregulated in those islets, as is GLP-1. This is data from Manal Mihara's group from the University of Chicago, and they show GLP-1 staining in the alpha cells in these NOD mice. So we think the same protective or pro-survival pathway may also be relevant in kind of the early phases of type 1 diabetes. And as we're not just mouse doctors, we need to figure out if all of this is relevant to humans. Okay, so we then take a look at human islet, and we wanted to know, do the same components of this pathway seem to play out there? So importantly, CCK is also produced in human islets, as are both of its receptors, although at widely variable levels. So there seems to be some regulation occurring, although we're not sure yet what is regulating these transcript levels in human islet. But we do know that if we take a human islet and we treat it with cyclic AMP, as we did to our mouse islets or our beta cells in culture, we can also upregulate CCK secretion. So this pathway seems to be active in human islet as well. And I already showed you earlier that the human islets produce GLP-1. So the whole components, all the components of the pathway seem to be present in human islet as well. So to directly test whether this is relevant in humans, we took human islets, again from deceased organ donors, and we treat them with cytokines, which induces beta cell death, as measured here by caspase 3-7 activity. And then if we treat them with CCK, we can blunt that effect, and we can basically reduce apoptosis in those human islets with the treatment of CCK. And then an in vivo model was important to us too, because when you're treating in a dish, it's a little easier to accomplish these things than it is when you're in vivo. And since we can't study beta cell death or beta cell survival in a living person, because we can't sample those beta cells to see what's going on, the alternative we have is to take a human islet and now put it into a mouse. So what we did here is we took immunodeficient mice. First, we induced diabetes by giving them a dose of that toxin, streptozotocin. So this is kind of a mimic of type 1. They basically have beta cell loss and they develop hyperglycemia. And then we take our human islets that we actually had pre-treated in culture with either control or with CCK, and we transplant them into these immunodeficient mice under the kidney capsule. And then the mice receive a pump that will continuously infuse either saline or our stable analog of CCK. So what we're mimicking here is sort of a type 1 diabetic patient who receives an islet transplant, which is a potential therapy for those patients. And then if we treat that patient with CCK or saline, can we protect them from death of the transplanted islet? After 3 weeks of therapy, we sacrifice the mouse and we take that kidney and we look at the human islet graft. So what I'm showing you here is some of those human islet grafts. So this is our control and this is our CCK treatment. So in many other studies that have been done in this similar fashion, we know that these human islet grafts undergo a lot of beta cell death and a lot of the graft is lost over time. So we can measure a fair amount of apoptosis in the control human islets. However, in the mice that were treated with CCK, those human islets are protected and they have much less beta cell death. So again, suggesting that in vivo, if we could treat with CCK as a therapy, we may be able to prevent beta cell death, either in a transplant situation or maybe even in type 2 or early type 1 diabetes. So in summary, I told you type 2 diabetes is primarily caused by reduction in functional beta cell mass, and that CCK is a potential therapeutic for diabetes and obesity because of its many pleiotropic effects throughout the body. Then what we've now discovered is that CCK is also produced locally within the beta cell and activated by GLP-1, which is also produced locally within the alpha cell. And this inter-islet signaling pathway we think exists to enhance beta cell survival both in the setting of obesity but also in the setting of early autoimmune attack in type 1 diabetes. And our hope is that these CCK-based therapies eventually may be used to prevent or reverse type 2 or type 1 diabetes. So in summary, I need to acknowledge the members of my lab who do all the hard labor here. So Carly Kibbe is a postdoc in my lab who has done the majority of the human islet data and the CCK transgenic experiments. And Amelia Lindemann is another postdoc in my lab who did the cyclic AMP regulation of CCK production. This work was originally started back when I was a postdoctoral fellow working with Jeremy Levine, and he has continued to work with me over the past years. And one of our endocrine fellows did some of the original work on the transgenic as well, Siri Sirenberevong. The rest of my labs all contributed in many ways, and then I need to thank my funding sources, including the NIDDK, the Wisconsin Partnership Program, the Institute on Aging, who has funded Carly as my postdoc and Danielle as my graduate student, and then the VA. And I'll take any questions.
Maybe two.
Yeah, in the middle there.
Is there potential for using CCK in a juvenile onset type 1 diabetic when they're in the honeymoon period or right after they get diagnosed?
Right, so the question is, could this maybe work in the honeymoon period for a type 1 patient? And yeah, that's what we think. So unfortunately, even at the honeymoon period, it's maybe a little too late. What we'd like to target is even earlier in high-risk individuals who have already developed autoantibody positivity, for example, but haven't yet progressed, because we know that there's about a probably at least a 5-year window where these patients are already having a reduction in beta cell mass and they're not manifesting until that gets very low, and that we'd like to hit them as early as possible. Okay, I'll take one more question over here.
Have there been any similar studies done using the GLP-1 analogs instead of the CCK?
Right. So the question is, have similar studies been done with the GLP-1 analogs? And the answer is some of them. So some of the in vitro work has been done with GLP-1 analogs. To my knowledge, like human transplant islet studies have not been done with GLP-1 analogs yet. And you asked about the side effects of CCK, and so that's one of the things that we're hoping to work on as well. So we want to understand exactly what signaling pathway is mediating this effect. And also, because we know CCK is produced locally in the islet, if we can understand how to turn on CCK production locally, we can minimize those systemic side effects, right? And then the final point there is CCK actually signals through 2 different receptors. And if we can target just the one receptor that's critical for this pathway, we may minimize off-target side effects as well. Okay, thank you very much.
Good morning. I'm delighted to have this opportunity today. So I'm going to switch gears and talk about exacerbation prone asthma and try to get us all to think about asthma in a slightly different way and perhaps even stimulate us to think about ways in which this might influence the care of patients in all of our clinics. So this slide is something that we've used for years in our medical school course, and so I'll ask you to take 5 seconds and complete this sentence in your mind with 3 words. So asthma is an inflammatory disease based on cellular inflammation. And this has been a revolutionary finding, but is now several decades old. We now understand asthma as a much more complex syndrome with several subsets. So certainly allergic childhood onset is a classic asthma phenotype, exercise-induced asthma, aspirin intolerant. These are all somewhat familiar, but we're beginning to understand that there are more commonly new phenotypes, adult onset asthma that tends to be non-allergic, obesity-associated asthma may be slightly different. There's an overlap syndrome called asthma COPD overlap syndrome, ACOS, that is certainly associated with smoking, and 30% of our patients with asthma do smoke, despite our recommendations. And there's a new phenotype that's beginning to be described that tends to be smooth muscle facilitated without a lot of inflammation. So asthma may not be exclusively an inflammatory disease. And it begs the question, can we match individual patients within these subsets to distinct treatment options? Wide open question. So the guidelines in this area are almost 10 years old now, and the process to update them is ongoing as we speak. To simplify those recommendations, the first 3 steps are pretty much inhaled corticosteroids in an escalating dose response here. By step 4, you add a long-acting beta-2 agonist. Step 5, you get a small increase in control with going up to a high dose of inhaled corticosteroids, but you really need to start thinking about a biologic therapy like omalizumab directed at IgE. And then step 6 would be adding maintenance therapy. There's certainly all kinds of other alternative strategies, and the table for this is too complex for this discussion. What we have understood now from primarily pediatric studies is that there is a pharmacogenetic preference, if you will, for different classes of medications. And 75% of patients do have preferential responses to inhaled corticosteroids, where the remaining 25% actually have a better response in lung function to a leukotriene receptor antagonist. But to this day, we still have no real good way to distinguish this up front in the clinic in terms of which patient will respond to which drug. So the guidelines suggested that at every visit we ask about nocturnal awakenings, rescue albuterol use, how much does your asthma impair your activity, and what about exacerbations? And this is summarized in statements about thinking about impairment in terms of quality of life, as well as risk for exacerbations and side effects. So how do I improve the care of patients in my practice? This is a quality paper that used a modified Delphi method. And the big findings will be summarized here. So use controller medicines as directed by the guidelines, no brainer there. Send someone in your office to become an asthma educator with a certification program. So the education should not rely entirely on the provider's shoulders. It's a team effort here. Assess control at every visit using a standardized instrument, and the two that have been recommended by the NIH are the asthma control test and the asthma control questionnaire. Give a written asthma action plan to the patient, and for HealthLink users, that can be found under the Letters tab. And then check spirometry once a year, and also with episodes of loss of control. And so my advertisement here is if you have a patient admitted for asthma exacerbation, please, please, please order spirometry before they leave. So, how about a real patient? This is a patient that I met in clinic a few years ago. She was 66 and was on prednisone bursts for exacerbations about once a month. She was a fairly active woman as a sheep farmer, but asthma was getting in the way of her life. She did have prior information to say that she was allergic to cats and dust. She was a little obese. She certainly had reflux and had been gaining weight because of all the corticosteroid exposure and was depressed because of that. You can see her medication burden was quite high. She had moderate obstruction on her spirometry and bronchodilator responsiveness by 17% with an absolute increase of 240 milliliters. Her exhaled nitric oxide value was above the normal limit, which is 25, but below 50, which is somewhat used as a threshold for defining compliance to inhaled corticosteroid therapy. And her IgE level was 306, and the upper limit of normal is around 150, although that varies from lab to lab. So she asked me the following questions. I really hate prednisone. How can I avoid it, and how can I feel better? And what's out there that's new? And I've heard about this thing called thermoplasty, and for those of you who were here a few weeks ago to hear Dr. Ferguson's talk, that's now approved and something that we're offering to our patients. So does my patient have severe asthma? So there are consensus guidelines now from the European Respiratory Society and the American Thoracic Society, and Dr. Jarger had the opportunity to participate in this group. And the brief recommendations here are threefold. So confirm the diagnosis, and in our patient's case, she did have bronchodilator reversibility. Other ways to do that would be perhaps more in a research setting, a methacholine challenge study. Sometimes you might have to rely on historic variability in spirometry with a classic history if your patient is very severe. So how do you distinguish this between severe asthma and lesser severe forms? So having 3 months or more of high-dose inhaled corticosteroids plus any secondary controller agents such as a salmeterol or long-acting beta-2 agonist, leukotriene receptor antagonist, theophylline, or frequent exposure to systemic corticosteroids. And then the third part is to define their control. And so you have to have at least one of these domains plus high-dose medication burden. So poor symptom control, frequent exacerbations, very serious exacerbations that land you up in the hospital, or persistent airflow limitation even after bronchodilation. So exacerbations are a major public health problem and drive decision-making about advanced treatment options. The COPD literature has described a phenotype subset of COPD called the exacerbation prone phenotype. And interestingly, in COPD, this is independent of smoking history and lung function. And there's really not good data yet in the asthma community to figure out whether this is a unique phenotype, especially when you think about including studies that have children. So the National Heart, Lung, and Blood Institute in 2011 funded 7 centers plus a data coordinating center to study this in the severe asthma research program. Dr. Jarger was the principal investigator for the Madison Center, and I'm a co-investigator and fortunate to be the co-chair of the exacerbation working group. So this is a longitudinal design, 3 years of follow-up here, We enrolled 714 patients across 7 partnerships at 14 clinical sites. 451 of these individuals qualified based on bronchodilator reversibility. 250 had evidence of airway hyperresponsiveness to methacholine, and then a small minority of subjects had lung function that was too severe to do the methacholine challenge study. The excluded patients are listed over here. And then our recruiting targets, we wanted the cohort to at least have 60% representation of severe asthma. 25% was intended to be children less than 18 years of age, and an equal balance with sex, and at least 30% minority. So we did meet these targets. 526 were adults, 188 were children. There was a very detailed baseline characterization period, and then a natural history longitudinal cohort design. So the frequency of asthma exacerbations at the baseline visit was determined by self-report. Essentially evaluating the number of systemic corticosteroid courses lasting at least 3 days with a 12-month recall. We had overlapping questions about other forms of parenteral steroid exposure as well as healthcare utilization. And I'll be showing the baseline data only today. And we divided these groups initially based on the frequency of the exacerbation history, those who had none in the past year, those who were few exacerbations, 1 or 2, and then those who were exacerbation prone, defined as 3 or more, which is a cut point we've used previously in the SARP network. So in terms of the baseline features across these categories, they're interesting that there are no differences in several markers that we typically associate with asthma. So gender, sex, duration of asthma, race, income, education were not associated with exacerbation frequency at all. We did evaluate medication assessment by a self-reported survey that is validated, and the reports were high across all 3 categories. So approximately 25% of our cohort was exacerbation prone. Interestingly, 40% of our cohort had no exacerbations, and then the remaining subjects fell in the middle here. As you might guess, there was an enrichment of severe disease in the exacerbation prone group, and so these are the numbers of subjects in each category and the column percent to show the highly significant enrichment in severe disease in this column. Across all categories of medication, there was an enrichment in use in the exacerbation prone group, and I show the data for high-dose inhaled corticosteroids as well as oral corticosteroids. There was enrichment in subjects with poor control, with low asthma control test scores in this group, and the exacerbation prone categories tended to be heavier or were heavier. This is absolute BMI for adults and then percentile BMI for kids. So lung function was a little worse, as you might guess, in the exacerbation prone group. So these values are percent predicted values of FEV1. And so, especially in adults, they were lower lung function in the exacerbation prone category. The effect size was smaller in children. And in adults only, we also found similar findings in the ratio of FEV1 to FVC, as well as the FVC percent predicted. Interestingly, there was no association across these 3 categories for methacholine PC20 values, but the sample size was limited to about 30% of the cohort. So bronchodilator reversibility was associated with exacerbation frequency, and that was somewhat surprising to me at least. So this is an unadjusted regression model with a negative binomial. So the fit values are the lines here, and the 95% confidence interval based on the sample size, and variance is shown in the spread here. Adults are in blue and children are in green. And this is the number of exacerbations in the past year. So as you can see, there's a nice relationship for both age strata between albuterol reversibility as measured in absolute change. So percent predicted post-albuterol minus percent predicted pre-albuterol in terms of how much their airways have dynamic opening and closing. So we were somewhat surprised by this. So unadjusted analyses of blood eosinophils by exacerbation frequency are somewhat underwhelming, despite all of the history of eosinophils relating to asthma. So this is the regression modeling here, and there's really only a trend here for the adults. So slightly higher levels of blood eosinophils in terms of their exacerbation category. Now, as I showed you, this cohort is highly medicated, and blood eosinophils are actively suppressed by corticosteroids. There was a little bit stronger relationship when we looked at sputum eosinophils, but this was only significant in adults and largely driven by sample size. We only had about 50 of the children with sputum samples. Exhaled nitric oxide is tightly correlated with eosinophil levels, but also highly variable. And the FeNO levels had no relationship to exacerbation frequency in either group. This was somewhat surprising to me as well. So exacerbation-prone asthma is not driven by allergic sensitization. Just think about that for a minute. It's counterintuitive. So here's the regression modeling. This is IgE values here on the x-axis, and exacerbation frequency again. And so in the adults, there's a very strong relationship such that the folks with the highest levels of IgE actually have the lowest frequency of exacerbations. Now, you might say, well, that's because they're on omalizumab. Really, only 6% of our data came from patients who were on this therapy, and the sensitivity analysis showed that there was no difference with or without inclusion of these subjects. How about with polysensitization? So on the y-axis here, this is allergen-specific blood IgE levels, so to ultranaria or ragweed or whatever you're interested in. And polysensitization is defined as having 4 or more positive IgE titers. And so in the blue bars here, it's the proportion of subjects in each of these exacerbation categories that have polysensitization. No difference in kids here in green, but a declining frequency of polysensitization in the exacerbation-prone subjects. So what about comorbid conditions? Well, the data here were largely driven to adults. Kids did not have a high incidence of comorbid conditions. As you might guess, given all the systemic corticosteroid exposure, there's an enrichment in reporting of hypertension, obstructive sleep apnea, diabetes mellitus, and osteoporosis in the exacerbation-prone categories, with the column percents here that are greater across these categories. The event rate for coronary artery disease was low. So whether this is the effect or the cause is unclear. Certainly you could implicate a role for corticosteroids. We did postulate, however, that 2 comorbid conditions might actually drive exacerbations, and those would be sinusitis and reflux. And so we looked at those here. And again, this is the proportion of subjects reporting positivity for sinusitis and for reflux across exacerbation categories here. And both in adults and children, there is an increase or an enrichment in patients reporting sinusitis as well as reflux. And we found similar results when we restricted the analysis to participants who reported actually having sinus surgery in the past, or were having active reflux symptoms at the time of enrollment, or were on acid suppression therapy. So our multivariable model is shown here in 2 slides. The categorical factors are first, and the continuous factors will be on the next section. These are adjusted for the factors on the next slide as well. So being Caucasian had a small effect that was not statistically significant. Sex had no influence on exacerbation frequency. Sinusitis and reflux had strong effects. Age was not significant with exacerbation frequency. Lung function gets a little worse. As I showed you, the effect size here is relatively small but highly significant. Exacerbation-prone folks, again, tend to be heavier, as I showed you. The inverse relationship with IgE held up after adjustment for multiple factors. And interestingly, the effect size for blood eosinophils was strengthened in our multivariable model, and now reaching significance again. These were also adjusted for clinical center as well as medication adherence report. If you take out FEV1 from the model and substitute it with bronchodilator reversibility, this parameter is also significant in this multivariable model. So to summarize the findings from the Severe Asthma Research Program and the exacerbation studies, there are striking differences between adults and children with regarding to exacerbation risk. 70% of the children with exacerbation-prone asthma have normal lung function, whereas this was only true for 28% of the adults. 26% of adults with no exacerbations were resistant to exacerbations despite the fact that they had very low lung function at baseline, and that's kind of curious to us. Kids had higher levels of type 2 inflammation across the board, and I didn't show this well in the interest of time, but these factors do not track with exacerbation-prone status in kids. I mentioned the bronchodilator responsiveness tracking with exacerbation history, and that sinusitis and reflux are strong predictors of exacerbation-prone status and could be causally related. So what do you do with patients who have severe disease? So clearly everyone should have information about allergen avoidance strategies and inhaler technique education, medication compliance assessment. If there's any question about this, think about a diagnostic trial with intramuscular steroid injections followed by a repeat assessment in 3 weeks. There are other measures for treatment of allergic rhinitis, including nasal steroid therapy as well as oral antihistamines and sinus rinsing, which may not get used as often. Think about screening for diabetes and osteoporosis as well as depression. And then we've started being a lot more aggressive for treatment of reflux, not just pharmacologically, but with gravity. Head of the bed elevation has a huge impact based on the physics of where our stomach is located relative to the esophagus when we're lying supine. Aggressive treatment for sinusitis and nasal polyps. Think about vocal cord dysfunction, which is present in about 30% of patients with severe asthma. Think about weight loss and screening for sleep apnea. And certainly, if you're getting up in terms of your step, certainly think about referral to an asthma specialist. So how did our index patient do? So I added a low dose of maintenance prednisone while I was working her up. We gave her lots of education and devices like a spacer and a peak flow meter. I taught her to do sinus rinsing. I gave her a bed wedge for her reflux. We started omalizumab, and she also started CPAP. So she kind of got the kitchen sink. And I'm not sure which one of those was the most helpful, but I reassessed her, and she was exacerbation-free for at least 18 months. We weaned off the maintenance prednisone, and we started stepping back on some of her other agents. So she started having exacerbations again this past year, but I had really weaned her high-dose steroids down a little bit too far. She was now into the medium-dose inhaled steroids, and so we kind of found her threshold at which she needs a steroid every day. So does your patient have severe asthma? So strikingly, Steve Peters did a national survey and published almost 10 years ago now, but at least at that time, almost 70% of patients with severe asthma are managed exclusively by primary care providers. So an opportunity exists, and about 3 years ago now, we opened up Advanced Asthma Care Clinic over at the West Side, housed in the space with the Allergy group. So there's allergist, myself from Pulmonary, and the primary care pharmacy group with a multi-D visit structure. And we're very interested in seeing patients with severe asthma who may or may not be on maintenance prednisone, and certainly patients who have frequent healthcare utilization. So some of the routine things that we do over there, everyone gets an asthma action plan. We try to minimize doses of inhaled steroids that are above the high-dose market label. We're very aggressive about sinus rinsing strategy and thoughts about immune therapy desensitization. Gravity works. Aggressive secretion management for patients who have evidence of high mucus production, and this is also variable in data that I didn't show you today, led by the imaging group within SARP. And then there is a little bit of data, and this is, I guess, off-label here. Montelukast is approved for maintenance therapy in the green zone, but there may be some emerging studies that suggest that it also works in the yellow zone. And then we think about triage for which patients do we think about biologics versus who should we refer for thermoplasty. So what about the therapies that are approved for patients with severe asthma? So certainly omalizumab has been around for goodness, 10, 15 years or more FDA approval. Thermoplasty is the newer kid on the block. Numerous studies here reviewed, I guess, down here with these references. So last year, we had approval for tiotropium, which has been approved for COPD for a while. The dose in asthma is half of what it is for COPD, and this is exclusively based on the Respimat format, so not the HandiHaler with the capsules and the powder. The Respimat dosing is half of what it would be for COPD, having similar efficacy in patients with asthma. And then mepolizumab got approved in November. This is a biologic therapy directed against anti-IL-5 with very powerful elimination, reduction, I guess, of blood and tissue eosinophil counts. And that's based on at least 7 trials. Certainly reduces exacerbation frequency. It can be used to liberate patients from maintenance prednisone and has some impacts on quality of life. There's a very rich drug pipeline here, and some of these agents are very close to approval. So biologics targeted against IL-4, IL-13, and then perhaps farther down the road would be agents against TSLP and IL-33. These are cytokines produced by the airway epithelium and have a profound influence in tipping the balance, if you will, towards type 2 inflammation. So we're kind of at this almost unique opportunity or golden age in asthma therapy in terms of trying to get towards personalized medicine. So some thoughts that we wrestle with in clinic. So the dosing of omalizumab is based on the patient's weight as well as the IgE level, and that leads to a nomogram where you think about either once or twice a month dosing. If it's twice a month, then mepolizumab is about the same price. And mepolizumab has a patient convenience factor. It's a much more humanized antibody, so you don't have to wait as long in clinic and worry about anaphylaxis like you do with omalizumab. So other questions are, how high does the blood eosinophil count need to be before you think of mepo as the first choice? So the approval threshold is 150, which is fairly low, or a historic value of greater than 300. But we see patients in clinic with eosinophils of 900, 1200. I mean, at some point you start to think maybe mepo should be the first choice. And then how much bronchodilator reversibility is required to trigger the decision for thermoplasty as the first option? And that's a very open question in the field. So in conclusion, exacerbation-prone asthma as a group may be less responsive to steroid-based therapy than other asthma phenotypes. Patients with EPA and low levels of IgE are actually pretty common, at least when you have the treatment burden that we had in our cohort. Blood eosinophils and bronchodilator responsiveness actually had the largest effect sizes in our multivariable models, and at least for blood eosinophils, this effect size was underwhelming in unadjusted models, but was strengthened in the multivariable model. And then NHLBI is thinking towards the future, and so the request for application for a new network will be coming out in the next few weeks with a deadline in the fall. And it's called the Precise Network. So this is really a clinical trial with an adaptive trial design. So the model that we've heard about is that there will be 4 treatment arms and an interim analysis. And if you're not doing well on one treatment arm, you move to the next. So that it's really patient-centered, if you will. So we'll certainly be applying for that and hope for the best. So with that, thank you for your attention. I certainly have to acknowledge Dr. Jarjur and Ron Sorkness, Seema Ramratnam, Sean Fain, and Mark Schiebler as the core investigators for our SARP group here. Gina Krisafi as our administrator, and Mike Evans as our local statistician. Dave Major and Brenda Phillips are the statistical core for the Data Coordinating Center. And then we have a great group of coordinators. So Holly Eversole led us off with the enrollment for SARP, and Lori Wallet has taken over now in the recruitment and the retention phase. These are the individuals involved in the adult version of the advanced asthma care clinic, and then the pediatric clinic is here. And I also have to acknowledge the allergy study call group, because they've been really helpful in some of these exacerbation studies are just really difficult because you don't have any timing, advance notice, and so we've had this call group that's just been fantastic to work with. So funding has been through NHLBI, and I've been very fortunate in that regard. So thank you.
this is bacterial sinusitis. Number two, how do you know this isn't just an epiphenomenon of sinus inflammation, of lower airway inflammation? Targeting that really is not going to have any impact on the asthma, of lower airway disease, or does it?
Yeah. Yeah, we don't know if it's bacterial necessarily. I mean, certainly there's an enrichment in fungal sinusitis as well. And so, I think of treating sinusitis more in terms of drainage pathways and really maintenance rinsing, if you will. So certainly there is a core element of asthma pathophysiologists who think it's a one airway hypothesis. So inflammation up here may non-specifically trigger inflammation down here. And so maybe if you can neutralize it, you might be also treating down here secondarily. But then I also think there's an element of just, and similar to the reflux, it's secretion management. If you got drip, drip, drip at night and then are sleeping and snort, you're inhaling that stuff down into your lower lungs. If you do a cross-section of the CT scan of patients with reflux, their stomach is about 8 centimeters above their esophagus. And so there's just, if you go to bed at an empty stomach, it's now in the upper airway and down into the